Hello, I'm Mary Ito, and welcome to the CRAM podcast. Are you a back pain sufferer? Don't worry, you're nothing special. And I mean that seriously because it's true. Most people, the vast majority of humans on this planet, will suffer from back pain at some point in their lives. And here's another terrible truth. There's no good evidence that many common treatments, and I mean really common treatments, for back pain actually work. So, what are those treatments? And why do we spend billions of dollars on them? What actually does work? These are big, important questions that affect us all. And here to provide some answers is Jason Busse, a Canada Research Chair in the Prevention and Management of Chronic Pain. He's also a professor in anesthesia in the Department of Health Sciences at McMaster University. Hi, Jason.
Hi, Mary. Nice to be with you today.
Yeah, so glad you're here. Why don't we start off and tell us what exactly is chronic pain?
Yeah, so chronic pain in the most sort of straightforward definition is pain that has persisted for 3 months or longer.
And do we have any sense as to how many people might be suffering from chronic pain?
Well, we do. So if you look in Canada, for example, it's about 1 in 5 individuals will experience chronic pain at some point in their life. So it's a fairly high number.
Yeah. And would that high number be true, like sort of on average in North America or Europe, like in other places around the world?
Yeah, in general, it does fluctuate a little bit. So you do find those rates go up a little bit or down a little bit. I mean, we do have some countries where we have very young populations, for example, and we know that chronic pain is more common as you age. So again, certain areas where they have very, very young demographics might be a little bit lower. Certain areas where you have older demographics might be a little bit higher. But that 1 in 20 number is reasonably reliable.
Okay, so you came to my attention. Well, I've known about your work, but you came to my attention again recently because you were part of this important paper that got published, and it got a lot of attention. You were looking at a number of interventions to treat chronic back pain. So I wonder if we can talk about that. And first of all, can you just tell us what were some of the common interventions that you looked at?
Yeah, so for this project, we were looking at spine injections. So this is when you'd have to go to a clinic, you would have to meet with a healthcare provider, and they would administer different types of injections to your spine to try to treat your back pain. Could be pain that was local, or it could be pain that was referred into your legs or even into your arms. And some of these injections could include injecting the muscles right beside the spine with either a local anesthetic or a steroid, or it could involve injecting that needle into the epidural space, sort of a space just above the spinal cord. And again, putting in local anesthetic or steroids. It could involve injecting steroids or anesthetic into the actual facet joints of the back to block nerves that are present there. Or they might put a needle or a probe next to a nerve and administer very high temperatures to burn that nerve root out, to sort of temporarily destroy it in an attempt to try to reduce your pain.
Okay, and just how common are these injections?
So they are quite common. We have clinics all over Canada, all over North America that are providing these, and they are increasing in terms of their frequency of use. So they do account for billions of dollars of healthcare spending every year.
And then with your study, what did you conclude?
So we looked at all the current best evidence that we could find. We found 132 randomized controlled trials. We conducted a very extensive type of analysis called a network meta-analysis. And we found that at present, the best evidence that we have shows that the procedures do not appear to be more effective than a placebo injection. So if someone goes in for treatment in a trial, and instead of, for example, having a steroid injected, they have saline injected, or instead of having radiation burn out a nerve root, they simply put the needle there but don't actually use any radiation. The results appear very similar. Now, a lot of that evidence was low certainty or moderate certainty, but it does at this point give us an indication that we don't have evidence for effectiveness beyond these placebo procedures.
Wow. So when I heard this, I don't know, like, which is more shocking. The fact that these treatments that are so common don't work any better than a placebo, or the fact that there have already been so many studies done, like you said, over 130, that don't support these treatments. Like, I don't know which is worse.
Yeah, and I mean, to be clear, some of the small studies did suggest that there could be a benefit. So I'll give you an example. Looking at these procedures where you use, intense heat or radiation to burn the nerve roots, called radiofrequency nerve ablation. We did find, I believe it was 11 randomized control trials. And there was uncertainty if there was an effect or not. And we explained that uncertainty by looking at whether the trial was blinded. So whether people knew what they were administering and knew what patients were getting. Those studies showed a fairly large effect. If we looked at the trials, the 7 trials that were completely blinded, clinicians didn't know what they were giving the patient, patients didn't know what they were receiving, then the effect disappeared. So we did have some studies that showed a benefit, but when we controlled for a risk of bias and other issues, those effects tended to disappear.
Do you know, there's something else I need to clarify here as well, because if you say that these treatments were no better than placebo, right? That some people might assume that means, oh, so they're not that good. But that's assuming that placebo is not that good, but maybe placebo actually is an effective treatment. So I think we need to clarify that.
Yeah, it's a great point. So people have always been curious about the placebo effect. So these are real benefits that patients tend to experience, but they're not due to the actual intervention. It's due to going through the process. So if we're doing a trial looking at a drug treatment, people would get a pill with no active drug in it versus an active drug. When we look at interventions, again, they would actually get the procedure, or they would show up, they do everything else you normally would, they'd have the needle put in, but there wasn't the intervention delivered. And there's now been trials where they actually randomize patients with back pain to either continue getting usual care or to get a placebo injection. And they tell them, we are giving you, one trial came out last year where they said, all we're going to do if you're in the treatment arm is we're going to inject 1 milliliter of saline, salt water, just underneath the skin where your back hurts the most. There's no active treatment here. This is a complete placebo. But they also told patients how powerful it can be to undergo an invasive procedure, how just doing that can have beneficial effects. And when they treated patients in this way, they actually showed a larger improvement than just receiving usual care. And those improvements were sustained up to a year. So what we have learned is that placebos can be powerful. These non-specific effects are real and they can persist. And it appears to particularly be an issue when you're looking at invasive procedures for chronic pain. So showing up, having someone sort of do something very invasive to you, patients have high expectations. They're expecting to get that benefit. They're undergoing this sort of invasive procedure, and that has an effect.
Okay. But the thing is, they know that it's a sham treatment.
Yes.
Like, they know that. So what's going on?
They've in this study, they actually did what we call a functional MRI scanning of patients' brains. And they showed that the patients that underwent this placebo injection actually had changes to how their brain showed up on these MRIs. So again, it's a real phenomenon. And the authors of this paper have actually argued that it is ethical to use open label placebos in clinical practice. They're saying, this has an effect and people should be allowed to use this. Now, that's very controversial. People are not using open label placebos in clinical practice very much, but it demonstrates that the effects that we see in practice, we don't know how much of that is due to the specific benefit of the intervention, which is why we have to do these clinical trials to disentangle the placebo effects from the specific effects.
Okay. What kind of feedback have you gotten from your study? I should say even pushback.
Yeah, I mean, it has been mixed, but I would say there has been disappointment and frustration from clinicians that are administering these procedures, that have
Yeah.
learned to do these techniques, that have built up practices. And of course, they have seen patients give them positive feedback, right? Which again, I don't doubt that. I don't discount that.
Yeah.
And so there is frustration around that, and the notion that, maybe if the studies were done better, maybe if they were done on a different type of patient, maybe if the procedures had a modification, then there might be evidence to support them. We are open to that. We encourage continued trials, and if people can demonstrate in a clinical trial a type of patient that benefits from a type of intervention, we would be delighted to change our recommendation. I mean, we just want to follow the evidence in a way that's consistent with what we currently have to look at. If the evidence changes, we would be delighted to change our recommendation.
Are any of the criticisms that you received fair about your study?
When I think back about the criticisms, there's been some saying, well, we think you missed some critical trials. And, these are trials where a lot of acute pain was also included, and we only looked at chronic. Some of the trials have said, well, we think that you shouldn't have combined some of these studies together. But what we did is we worked with 6 clinical experts that perform these procedures as part of their practices. And we had a lot of discussions, does it make sense to combine these studies together or not? Sometimes they said yes, sometimes they said no. And then we also did quite a few statistical tests to see if it made sense, if these studies were giving us similar estimates. So I gave you the example before when we looked at those radio frequency nerve ablation procedures. When we put all those trials together, it looked like there was some different effects that were being contributed, which we could then explain by looking at whether or not studies had been blinded. So we feel that we're able to defend our approach. We did undergo quite an extensive peer review process. We published our protocol before we started our study. So we really stuck to what we said we would do. But again, I do understand the disappointment and to some degree the frustration of clinicians that might look at our results and say, but that doesn't seem to reflect what I see in practice. So what's going on here?
Yeah, I have a feeling it's more than just disappointment. I don't think anyone likes to be, to hear that, or what you do is kind of useless.
or
really,
doesn't have sort of an effect beyond
a placebo.
Yeah.
So let me ask you then, if you were a medical doctor and you had a patient coming in to see you now, and this person has, chronic back pain, and they say to you, okay, I'm thinking I should get an epidural injection, or one of the injections that you studied. What would you say to them?
Well, I would say, I understand, why are you now sort of considering this? Have you tried other interventions that might be less invasive, that maybe we have better evidence for? And if they've said, listen, I've tried everything and I've really heard some interesting things, I want to explore it, I would present them with the evidence. I would say, listen, there are a lot of clinics out there and it's easy to acquire these procedures, but I want to tell you what we currently understand about the best evidence for benefits and harms. And I would want to inform them so that they made that decision given more information. At the same time, people are desperate, right? People that have exhausted other therapies, they may say, listen, I got to try something, and so I'm going to do it. And you see a lot of people pursuing a lot of, untested therapies in general for chronic pain because of that desperation. And we have lots of examples of that, unfortunately. So again, I would want to try to provide the best evidence so they can make a fully informed decision. I'd want to let them know the kinds of interventions where we do have some evidence of benefit, and hopefully get reassurance that they had tried those things first. But, I would be uncomfortable providing encouragement given what we know.
Yeah, because this is a tough one. I mean, I sympathize with what you say about patients who are just at their wits' end. They've had so much pain. They've tried different things. They don't know what to do. And perhaps they think that maybe this injection might help. And the interesting thing is it might help. Based on what you've
Yeah.
said, it actually might help because of that epidural the placebo connection.
Yes.
The only thing though is like it's not as if it is nothing, because injections in and of themselves have risks.
Yes.
So right there, right? So right there, there's a risk. Also, well, you just said earlier, like this is billions of dollars. So it's not nothing either. And those billions of dollars, I don't know. I mean, if we were to take some away from there because, the evidence shows they're not working as well as they should, like where else could that money be spent? Do you know what I'm saying?
Yeah.
So
No,
I don't,
it's a great point. And we do know, for example, you have about a 0.7% chance of developing a deep infection. We know that you've got about an 8% chance of developing, persistent pain from the procedure itself. There has been very, very rare, but captured cases of people that suffer catastrophic injuries. The needle actually goes into the spine and causes paralysis. Again, that's very rare, but you're right. I mean, these complications can occur. So if we're not seeing any specific benefit, it's very, very difficult to make the argument that a procedure is worth undergoing. And the cost is substantial. These are very expensive procedures.
right.
We costed them out, for example, if you went to, some of the main hospitals in New York and had one of these neurofrequency ablation procedures, that's $5,000. I mean, these are quite expensive procedures to undergo. And I think one of the problems that we've come up with for whatever reason in Canada and in North America is we've tended to invest very, very heavily into interventions that are not particularly effective or in some cases ineffective. And we've not funded things that tend to be much more effective. So 10, 15 years ago or 20 years ago, there was the idea that all we had to do was prescribe large amounts of opioids for chronic pain and that would solve the problem. Fast forward to now, we now understand that the benefits are quite modest. They won't work for most people. Harms are greater than we thought. Now we're turning to cannabis, right? So we're repeating the same experiment again without solid evidence that there's good net benefit. And at the same time, we do have good evidence that many people that are dealing with chronic back pain are likely to benefit from sort of what we call more of a biopsychosocial approach, where we help people become more physically active, where we, teach them ways that they can safely start to re-engage in normal activities, where we provide different types of psychotherapy to help them manage their symptoms different or to cope with them in a different way. And at the same time, these tens of therapies, one, we don't pay clinicians very much to provide them, and we often don't reimburse them. So you really can only get these types of therapies, in hospital settings or if they're provided by physicians, which in most cases they aren't, right? So,
okay. So you're talking now about the evidence to show what actually does work,
yes.
right? Yeah. So let's talk about that. So now I'm a patient. I'm coming in to see you, my doctor, and I say, oh my goodness, I've been suffering from this chronic pain for at least a year now. What can I do? What do you recommend that will help me?
Yeah. So the World Health Organization last year put out guidelines on this topic. And again, the caveat is, even what they recommended was largely supported by low or very low certainty evidence. So they really felt that more work needed to be done, which is kind of amazing when you consider how much research has gone into this question.
Yeah.
But what they did is they recommended, they said, we do have at least some evidence, although in many cases, low or very low certainty, to suggest that patients may benefit from use of non-steroidal anti-inflammatory drugs like aspirin or ibuprofen. They may benefit from an exercise program, but again, it has to be tailored to the individual. Multi-component biopsychosocial care, where you combine psychotherapy with activation. They did find some evidence to suggest acupuncture may be helpful to some people. They found some evidence to suggest that perhaps cognitive behavioral therapy or operant therapy, spinal manipulative therapy, or massage. So again, they didn't have high certainty for any of this. So they can't say we can absolutely conclude, but they said the evidence that we currently have suggests that patients may want to look at these types of interventions if they're seeking relief from their chronic pain.
How is this possible that there's such poor evidence around this with, again, the billions and billions of dollars that have been spent in this area?
Yeah, I mean, but again, I kind of go back to the opioid example. How is it that we became so engaged in this sort of high level of prescribing with the evidence? And the reality is, there just doesn't seem to be this enough of an expectation that we're going to have rigorous science before interventions are sort of brought to the marketplace. And so I don't know if there needs to be more work with regulators and policymakers. The other problem is sometimes patients are desperate. I think back to the situation in Canada a few years ago where there was a, very promising technique that was going to cure multiple sclerosis for lots of people, right? And it was this sort of controversial vein stripping technique, and the patients wanted it. They said, this is a devastating condition. We want the government to pay for this. There was 6 small trials, I think, out of Italy. And the government said, we know you're desperate. We know you want us to start paying for this. We're a little nervous. We're going to sponsor a randomized control trial first. They did the trial. Unfortunately, it didn't work any more than a sham procedure. And so they said, we're not going to fund this. I'd like to see similar things done for chronic pain, right? But we have all these interventions that are currently out there. And now I feel it's almost like research has to catch up to see, do these things work?
Okay, I want to take now like a sort of a different approach to this whole issue of chronic back pain. First of all, I said at the beginning, more likely than not, almost everyone's going to suffer from back pain at some point in their lives, right? So what do we know about that worldwide?
Yeah. I mean, having an episode of acute back pain, it is going to happen to almost everybody. I mean, I've experienced a few, and they are incapacitating. I mean, it is astounding how painful they can be. So I get it. It's a miserable experience to go through. But then we've had studies that have looked at what seems to predict whether or not people go on to develop chronic back pain, because that's less common. It's still pretty common, but not everyone is going to experience chronic back pain. And there was a study published, a big review on this topic in the Journal of the American Medical Association about sort of 15 years ago now. So it's a little bit older, but the results are probably still fairly robust. And what they found was there was about 5 factors that predicted people that went on to develop chronic back pain, and 2 factors that seemed to be protective. And the factors that predicted that you were likely to develop chronic pain is if you were really struggling with sort of coping with the pain during the acute phase. If you also presented not only with pain, but with mental illness as a comorbidity, anxiety, depression, something of that nature. If you're already dealing with sort of low general health, this is sort of one more thing added on to the burden you're experiencing. If you experienced very high sort of functional impairment, at the time, that was, again, a negative risk factor that you were likely to go on. If you had something called, they call it non-organic signs, but symptoms that don't seem to have a clear explanation for what we understand about, injury or pathology. And then there was a couple of factors that seemed to protect people, made them less likely to develop chronic pain. If they had low fear avoidance. So if they said, I know I'm feeling this pain, but I feel I can still do, a number of things throughout my day, my activities of daily living. That was protective. And again, if they had sort of pretty low functional impairment. So yes, I have the pain, but I'm still sort of proceeding and going through my sort of things I need to do, which again is sometimes easier said than done. And building on that work, there was a really interesting, large randomized controlled trial out of Australia that was published last year, where they took 700 people that were experiencing an episode of acute back pain, and half of them got usual care. And the other half, they gave them some education about, listen, this is typically self-limiting. It's not dangerous. You're okay to go forward. There are rare cases where acute back pain can be a sign of something more ominous, but very, very, in most cases, it's not. And that group got the education, and they also got a walking schedule, which they were encouraged to follow. And they showed much lower chances of going on to develop chronic complaints in the group that got this education and activation. So a very, very simple intervention. It was all done
Mm-hmm.
remotely, but a very, very powerful effect. So, I mean,
Yeah.
understanding that very often it's these psychosocial factors that tend to predict the progression to chronic pain, we should be able to provide interventions at people at risk to reduce their chances. And ideally, we can sort of find people that already have chronic pain and provide them with, again, these sort of less invasive, less dangerous,
Yeah.
less
Yeah.
costly interventions that encourage them to, have more
Yeah.
optimal coping and greater functioning.
So, um, the thing about, I mean, that study sounds impressive because the solution seemed simple, right? They had education and they were given a walking schedule. And I just want to go back. These people had an acute bout of pain.
Yes,
Is
yeah.
that right?
These are
Okay.
people coming in, and it's
Yeah.
like,
Right.
and
Okay.
the outcome was avoiding a
Right.
reoccurrence of their
Okay.
pain.
So the thing is, from that group that did so well, how do you tease out the fact that almost, I'm assuming all of them probably, or almost all of them, would have eventually gotten better anyway?
Yeah.
They would have gotten over their episode of acute back pain
Yes.
anyway, right? Because that's what we know.
Right.
We know that with acute back pain, you usually get over it down the road.
Yeah.
In a few. Yeah.
You're exactly right. So what they
Yeah.
wanted to do was to look at because if you've had an episode of back pain, you're very likely to have another one. Right? Having an episode of
Okay.
back pain is a risk factor for having more, unfortunately. And they wanted to find out, the question they had was, how do we prevent those reoccurrences? The more reoccurrences you have, the greater chances something's going to become chronic. So that's what they wanted to tease out. And so they had the usual care group. It's whatever you're normally doing.
Right.
That's what you're going to do. And then the other group where it was, as you said, it was a fairly straightforward intervention, education and activation, but in a structured way, and giving people confidence. And that demonstrated this very large benefit in terms of much longer time before they even experienced any kind of reoccurrence again.
Okay. You know what though? Can I just go back? The fact that most people will get over their acute back pain bout, right? Is that well known? I don't know if most people realize that, because I feel like a lot of people I know who have an episode of back pain, they feel they need to get help right away. They got to do something, right? They got to get medication or get some kind of therapy.
So I think you're right. And one of the reasons I think you're right is there was a really interesting experiment that was done again in Australia. I mean, they seem to be leading the pack in this area for some reason. But there was a very accomplished rheumatologist out there who said, you know what? I don't think people do understand that a lot of times these conditions are self-limiting and they're going to get better. And sometimes if you get into a lot of treatment, it can sort of keep you in that system. And they put out a public health campaign. So really what they did is they used billboards, they used radio ads, they probably used podcasts, and they just to get that message out and to say, listen, most acute back pain is not dangerous. It tends to be self-limiting. You're okay to get active again. In fact, it's good if you do so. And then they tracked the sort of healthcare utilization for back pain, and they saw a real dip. And so getting out that message had a very powerful effect in terms of encouraging people, I think, to take more ownership and to be less concerned that they had to immediately go to seek care. So I think that seems to be a powerful treatment modality as well.
Yeah. But again, just going back, as you said earlier, there are things that you can do that can actually help alleviate the back pain, even though you may eventually get over it, right?
Yeah.
Like exercise and certain modalities may help
and
you.
The timing of that. So again, when I was talking about those modalities, that was more for the chronic back pain. That was
the chronic. Okay.
World Health Organization for chronic back pain. And they said, listen, if your pain has been around for a long time, okay, here are some things because it's not going away on its own for you.
So the other thing too, it makes me wonder, if we've had such a hard time with our research in finding not even a cure to back pain, but even, treatments that are effective, that have solid evidence behind them. And you're saying that almost everyone in the world is going to suffer from back pain at some time or other. What about just accepting that this is a normal condition of human life?
Yeah, that's what that educational program was really targeted at. It was sort of normalizing the experience. And again, I'm very sympathetic about how painful an acute attack of back pain can be.
Yeah.
I've been there. I've gone through it. I mean, it's paralyzing. It can be so intensely painful. So it's very difficult to sort of not be concerned about that. But I think you're exactly right. I mean, if we can find ways to sort of normalize the experience, give people confidence, unless you're seeing some very ominous signs that would be indicative of something more serious. You lose control of your bowel or bladder. Your legs lose sensation. Rapid weight loss, night pain, and fever. There's certain ominous things that would sort of indicate you maybe need to get this checked out. But that doesn't represent the vast majority of back pain.
So if you don't mind my asking, can I ask what you did when you had those acute episodes?
It's the funniest thing. So we know that when you're sort of sleeping at night, your those discs in your spine tend to get a little bit plumper, and it actually increases instability. And so when you first get up in the morning, you could sometimes do something so silly like bending over to tie your shoe, and your back can, go into spasm. You have this terrible pain. And as I said, it is just incapacitating. So what did I do? I moved very, very carefully for a couple days. I definitely was probably, trying to lie down and just not move too much. And then I said,
was that the right thing to do?
Well,
should you actually lie down or should you move?
Well, for that first 24 hours, when you're really in that terrible, terrible spasm, it's tough to do a lot. It is tough to do a lot. And then I just said, okay, I got to start getting up. I got to start moving.
Yeah.
And I know it hurts a lot. I know it hurts a lot. And I would just do things to try to reduce the amount of, loading that I put on my back. So if I had to brush my teeth, I would put my hands out on the sink in front of me to take that load instead of making my back try to do the work when the muscles were all seized up and painful.
Right.
If I had to bend over, I would go down, using my legs to bend. I wouldn't bend over at my back. If I had to turn, I'd turn my whole body. I wouldn't sort of try to turn at the waist. So I tried to minimize the sort of stress and loading that I put on those very irritated tissues, but get myself moving and active. And it did go away. But those first couple days, very, very painful.
Very bad. Yeah.
Absolutely.
See, it's interesting. So it did go away, but also because you're in the know, I'm assuming that, you knew, okay, this pain is terrible.
Yeah.
It maybe it's unbearable, but I know that it's not going to hurt me. I know that I'm not in danger, right? Because fear is a terrible thing for people.
You're exactly right. I mean, I was able to make that sort of logical step. I felt intense pain, intense discomfort, but I knew that it was not something that I needed to sort of be too worried about. It was going to be an awful couple of days, and then it was going to go away. So understanding that allowed me to make sure that my prognosis was quite good.
And okay, can we just chat a little bit as well about what do we know about the role of surgery?
Yeah,
how effective is surgery? When should we be considering it?
Yeah, it's a big issue because if you took advanced imaging, an MRI, for example, of anyone who's an adult, you're going to find things that look a little bit off, a little bit of a disc bulge, a little bit of degeneration, a little bit of narrowing. But are these things important? Do they have any sort of clinical value? And we know that there's a lot of unnecessary referrals for surgery. So there's a very, very smart spine surgeon in Toronto, a guy named Raj Ramprasad. And he noticed that 90% of the referrals coming to him were unnecessary. And he said, why is this happening? And it really was people presenting to their primary care doctor with a lot of pain, a lot of concerns, and their doctor just saying, well, I'm not sure, so let's just send you on for the referral. So when is surgery appropriate? Well, we know you can have, and again, these are very rare cases, but you can have something where your disc herniates and it's pushing right on the spinal cord, something called cauda equina syndrome. That's a surgical emergency. It's very, very rare. And, you have a loss of control of bowel and bladder function. You start to develop, numbness down both legs. So it's a very, very dramatic presentation. Sometimes when people get older, they develop narrowing of the spinal canal, something called a stenosis. And if that gets to the point where it's putting enough compression on the spinal cord, they may need to get some decompression done surgically. It is possible where you can have, vertebra of the low back start to slide forward. That can cause, compression on the spine as well. So there are cases where surgery is very important and valuable. But the vast majority of cases of low back pain, even chronic low back pain, are not going to be candidates for surgery. And you've seen surgeons, I think, become much more conservative over time. It's quite rare now for a surgeon to be interested in taking a case for local chronic back pain that's right on the spine, as opposed to if you have referral into the leg. And those are the ones they tend to be looking at more carefully now.
Would that be true? So I'm assuming you're talking about Canada. Would that necessarily be true outside of Canada?
I think in general, there's sort of a lot of understanding that with chronic back pain, less is often more. Less invasive approaches, less surgery. Let's look at, as you said, what we call the tincture of time. Can these things sort of resolve? So I think there was a period where there was a lot of surgery being done. And then we unfortunately came up with a new diagnostic category called failed low back surgery syndrome, right? Because when you're going in and you're sort of modifying the tissues, you are creating changes. You are creating scar tissue. You might end up cutting something that you didn't mean to cut. And so there can be consequences for these invasive procedures. And so there's a lot of sort of, I think, greater awareness now about, do we really need to do surgery? Is that the best thing for this person? And have we really exhausted more conservative avenues first?
So, and finally, for people who, let's say, the lucky few who haven't had a terrible bout of back pain, or maybe even people who've had some back pain, but, knock on wood, they're hoping this isn't going to happen again. Is there anything that they should be doing that can actually prevent another episode or any episode? First episode.
So I'm not as certain of this as I should be, but in general, we know that if you are keeping yourself in better shape, that is more likely to help you, right? So again, I mentioned before with that prognostic study, people that have a low level of general health when they have an acute episode of back pain are more likely to then have it become chronic. So the problem is, many of us now have jobs where we don't move very much. We're pretty sedentary. We're quite busy. It's hard to get out and stay active, especially as we get older. But that seems to be something that's important. I mean, if we can encourage better levels of activity, better levels of fitness, that's probably going to help reduce our chances of ending up with chronic pain.
Yeah. Well, in that case, then, do you know whether we are seeing more back pain, like people saying that they're suffering from back pain more so now than like before, sitting at our desks all day long in front of our laptop? Do we know whether that's increased?
I believe I have read some studies that have suggested that for a variety of reasons. So, lower levels of activity. But you can also make the other argument that people that are intensely physical active in very, very demanding jobs might be more predisposed towards developing an injury or having something happen. Yeah. So it's going to be a matter of kind of a right balance. There are certainly jobs where people are under much more hardship physically than they are otherwise. We also tend to have more challenges psychosocially, people being more disconnected. People have heard and talked about these sort of loneliness epidemics and people working remotely. And there's a lot of factors that might come into play that might lead people to becoming more vulnerable to chronic pain.
Yeah.
But I wouldn't be surprised if, general lowering levels of activity would be a part of that.
Just going back to your study, just because your study and all those or many of the other studies that you looked at did not show that there was good evidence to back these interventions. I mean, what do you think would be the next step then for this kind of evidence? What's the role of the government that covers through, in Ontario, OHIP, but in other provinces or in other countries, they're covering these procedures.
Yeah.
What should they be doing or thinking about?
Well, going back to that one example I gave of that, very potentially interesting therapy for multiple sclerosis, which people really wanted, right?
Yeah.
And the government, I think, did such a smart thing. They said, let's get some good evidence before we make the decision. I would like to see some investment in, I mean, if there are groups of clinicians out there that say, we really think that we can demonstrate benefit in a certain group of patients, for example, I would love to see investment in high quality, rigorous trials to show that. I mean, we did make the point in our article. Many of these procedures that we looked at are currently only supported by, low certainty, in some cases, very low certainty evidence. And it would be quite reasonable to provide them in a research context. Like, let's do those good trials. Let's demonstrate, better evidence so we can make better decisions. So I would like to see the government get involved in that. But at the same time, I would really like to see them make some investment in some of these interventions that we do have evidence can be effective, that are currently difficult for many patients to access because they're involved with out of pocket costs.
Okay, what about this? What if a patient goes in to see their doctor and they want one of those injections, right? And the doctor, as you said earlier, lays out the evidence, the current evidence, right? And says, this intervention, it's not shown to be effective, or it is as effective as a placebo. So let me offer you a placebo first. Okay, a placebo injection. You see how that works. And then if it doesn't work, you come back and then we'll consider maybe giving you.
Yeah.
What about that?
Again, there are groups. There's a very prominent group out of Harvard that has been arguing for that. They have been arguing for the ethical use of placebos in practice. It has not been adopted. I think it's, it's a very interesting concept.
But the thing is too, you are telling them,
yes,
right?
You're telling
it's not like you're doing it in secret. You're saying, hey, do you want this or not? This is what the evidence has shown.
You're exactly right. And there is a group advocating for this. It has not been widely picked up. It remains controversial. So they're going to keep having to do more studies. They're going to have to see if this is something that they can ethically justify. But it's an interesting concept, right? Let's do something, because doing something is probably going to be better than doing nothing.
Doing nothing. Yeah. And it makes me also think, don't you think that more research then needs to be done on this whole like mind-body connection, right?
Absolutely.
Yeah.
Absolutely.
Because you're telling me there's such a strong association, and that also part of effective treatment is psychotherapy.
Yeah.
Like, right.
I really, I mean, there was a very important series on back pain that came out in the Lancet a few years ago, very, very prominent journal. And they really made that argument. They said, for whatever, we need to completely rethink how we are managing back pain. We have been focused for so many years on finding a specific lesion that we can inject or cut or medicate. And it really hasn't been very successful. I mean, yes, there's a few cases where someone does have something readily identifiable that responds, but in the vast majority of cases, no. And they said, we really have to start thinking about these sort of, the sort of central processing of these sensations, and how that might be a more promising avenue for a lot of people.
Can I just stop you? Is that because most back pain, like mechanical back or non-specific back pain, it doesn't show up on a scan, does it? Like, you can't point to something on a scan and say, well, that's the back pain.
Right. Not with confidence. Again, if we did imaging, if you and I did images of our back, we would find lots of things to look at. But in terms of, saying this clearly is the cause of your problem, about 90% of chronic back pain, we cannot find an identifiable cause. And so we call it non-specific back pain or idiopathic back pain. And again, it's not to discount people's experiences. I mean, they are feeling pain. The pain is real. It's terrible to live in pain. There's no doubt of that. But I saw one fascinating TED Talk. There's a neuropsychologist, and again, I don't know why, Australia again. And he was just sort of talking about his own personal experiences where, he used to go to this like little swimming hole on a regular basis, and he would go in flip-flops in his bathing suit. through the forest to this lake. At one time he was walking down there and he felt a little scratch on his ankle, and that's the sensation that went up his spine. Okay, here's a little physical sensation, and it went to the brain. Then the brain has to interpret it. And the brain says, have you experienced something like this before? What is it likely to mean? And he said, yeah, I'm walking through the forest. I probably got scratched by a stick. No big deal. Kept walking. Half an hour later, he was in a coma. He'd been bitten by a incredibly poisonous snake. And he was lucky. He got treatment. They gave him the antivenom. He recovered from this. The next time he was walking to go to this pond, he felt a little scratch on his ankle again. This same signal went up again, up the leg, to the spine, into the brain. This time the brain said, oh my gosh, you almost died last time. This could be another deadly snake. He felt incredible pain. He pulled his leg up. He screamed and he looked down and it was just a stick. It was just a stick. The same stimulus up through his nervous system, but interpreted very, very differently. And this seems to be something important with many forms of chronic pain as well. It is completely real. It is completely real. But if we can sort of change some of the central processing for how we interpret these signals, it might be very powerful. And there are techniques people are working on. They've been putting out trials, some very, very interesting, promising stuff that it would be nice to see more resources put into.
That is a fabulous illustration. That's a great story. Okay, can I just end off then? What do you think is the most important information, advice that you can impart to people right now who may be dealing with back pain? Like what would you say to them based on all this evidence, everything you know?
Yeah. I would say I understand the sort of temptation to go for something where they are going to fix everything. You just get this one shot or this one procedure and you're done. With chronic back pain, the more we learn about it, in the vast majority of cases, once something very sort of serious has been ruled out, recovery tends to be a process and not an event. And that process often tends to involve how do we get strategies to increase your level of activation? How do we deal with other types of stress in your life that might be affecting how you're coping with this? And how do we sort of encourage more ownership and sort of self-reliance in terms of recovery? So great if you find something that gives you some temporary relief where you have to go see somebody, but ultimately the goal is to continue to try to get more functional in terms of your daily activities, in terms of what you're doing, so that you can become, more the expert in your own pain and find out ways that are going to help you move forward.
Excellent. Loved speaking with you, Jason. Thank you so much.
Thanks so much for the opportunity. Great to be with you as well.
Jason Busse is a Canada Research Chair in the Prevention and Management of Chronic Pain. He's also a professor in anesthesia in the Department of Health Sciences at McMaster University. For more information on Jason, his research, and also his recommendations on 2 excellent books to help you deal with chronic pain, you can check out our show notes. That's it for the CRAM podcast today. We hope you enjoyed it. Please follow us on social. Our handle is @CRAM Ideas, and we'd really appreciate your support. If you'd like to make a financial donation, just head over to our website at cramideas.com. Thanks for listening, and see you back here next time.